Welcome to AT4U listening podcast. Today we are going to discuss about colitis and Crohn's disease.
Talking about Crohn's and colitis.
Yeah.
So let's talk about, first of all, the difference. What is Crohn's? What is colitis?
So what I would say is that in order to understand that, you got to look at the 10,000-foot view, and those go under what's called inflammatory bowel disease, or IBD. And really, when you talk about Crohn's and ulcerative colitis, you really have to think about there's actually a third one in there that doesn't maybe get enough street cred out there, and that's indeterminate colitis. And so there's about 15% of people that have a little bit of a ties to both of them. We can't really determine one or the other.
Okay.
There's some major overall differences between one. Typically UC, when we think about that, we think about the fact that it starts at the anus and works its way backward and only is involved in the hindgut, the colon, the rectum, and the anus. Versus Crohn's can occur from mouth all the way down to anus.
Okay.
Both of them can have extraintestinal manifestations, meaning that they can have things that go up on your skin or your liver or your eyes, stuff like that. And then Crohn's tends to fall within kind of three different phenotypes, the way it manifests itself. Crohn's will either be a stricturing type disease, it'll be a fistulizing disease, and for people out there listening to the podcast that don't know what a fistula, think about a tunnel, something from one end to the other. It's got an opening, versus a sinus, which is like a cave. It's got one opening and it just ends blindly. Or it can be phlegmonous disease, so that it's got these large inflammatory phlegmons. So stenotic fistulizing or phlegmonous type disease. Ulcerative colitis, again, tends to be mucosally based and typically involved in the colon, the rectum, and so it's those. They're kind of under that umbrella of IBD, but there's three of them, indeterminate with a little bit of on each side.
Now, when you talk about UC, that's ulcerative colitis. Is there a difference between that and just colitis by itself?
Yeah. So colitis is just a general term. Remember, where you add itis to anything and you got inflammation.
Okay.
So, deskitis, inflammation of the desk. I mean, that's just the Latin term of what itis is. And so colitis, a general term, just means that the colon is inflamed. It can be from infectious type issues. You get a bad stomach bug and your colon gets inflamed. C. difficile is a very classic one. Ulcerative colitis is an actual disease entity in and of itself, of which the colon being inflamed with a very typical manifestations of it is a part of it. So that's a true diagnosis versus the generalized term colitis.
Okay. So can you have both ulcerative colitis and Crohn's?
That's a great question. That goes back to that third one that I was saying. That's the short answer is no. The longer answer is that there's definitely a spectrum, much more. We in medicine like to kind of make things into nice tight little boxes. It helps our minds go into it, but in reality, there are those patients. We always say there's about 15% of patients that you may think have one disease that ultimately turns the other. The classic one being that patients get diagnosed with ulcerative colitis and they ultimately have Crohn's. And the way that manifests in many cases, especially on the surgery side of the house, I'm a surgeon, is they would get a surgical therapy for their bowels. For example, we take out their abdominal colon, their rectum, and we make them a new rectum called a pouch. And then down the road, they may manifest with Crohn's disease. So there's a small chance of that. So it's not like they caught Crohn's or something like, you caught a flu bug out there. What it is more they probably fell on that spectrum that they initially presented much more like UC, but kind of Crohn's was lurking. And that's not a common, but it's also not an uncommon type, unheard of pathway.
So between Crohn's and ulcerative colitis, it looks like location is the difference, the biggest difference, right? But what are some of the shared symptoms besides something like inflammation?
Yeah, so they both can get problems associated with their GI tract. So they can get diarrhea, they can get belly pains. The colon can be involved in both. You can have Crohn's colitis in both versus ulcerative colitis. You can have extraintestinal manifestations in both, that they both have skin disease or maybe has some arthritides. There's no question that between the two that there's certain extraintestinal manifestations that may occur with one of the two versus the other. Ulcerative colitis and having primary sclerosing cholangitis, which is an inflammatory condition associated with the bile ducts in the liver, for example, just one. But the major difference between the two is not only the extent of disease from mouth all the way down to anus with Crohn's versus just the colon and the rectum with ulcerative colitis, but it also is the thickness of what affects the bowel. So, for example, if you think about the bowel wall, think about a Big Mac. You got the bun, and you got the muscle, and you got the other bun, and that muscle being the meat patty within that, and you got two all beef patty special sauce, just a two-step deal. The bowel itself, on a histological level, has mucosa, submucosa, muscle, and then serosa, then adventitial tissue. So it's got layers to it. So ulcerative colitis just affects the most superficial layer. It's a mucosally based disease, versus Crohn's disease can affect all layers of the bowel. So even though the bowel is very thin, if you feel it, Crohn's can go all the way through. And so that's a very classic one. And that's why in Crohn's disease, you get things like fistulas, because it can go all the way through the bowel, versus if you see a fistula in the setting of ulcerative colitis, you should think, God, does this person have Crohn's disease?
Right, right. Okay, so let's explain what fistula is to those who don't know.
So there's lots of different type of fistulas. When we talk about a fistula, again, it's a tunnel or a tract from something to something. Classically, in Crohn's disease, there's a couple of different type of fistulas. The first one is on the bowel, and that would go to another organ. So an entero, meaning small bowel, to cutaneous, to the skin. There's a connection between them. They drain bowel contents through there. Or an enterovaginal, through the woman's vagina, or to the bladder, enterovesical fistula. They're named between where they come from and where they originate to. And because Crohn's is primarily a bowel disease, the inflammation is in the bowel, that second organ is oftentimes just a bystander, just happens to be there. So the fistula is a tunnel going from the pathologic bowel to the bystander disease and causing that. The other part of the fistula that we see very common, especially in Crohn's disease, understanding that the vast majority of fistulas of this type are just run-of-the-mill luck, and that's perianal, so around your bottom, around your anus. So you can get fistulas in these type of diseases that occur with both Crohn's disease, but the much more common thing is you could have a fistula associated with non-Crohn's that is just originating from the little glands down there that make mucus, so that you get a little bit of grease when you got to go to the bathroom that come out, and those glands can get infected, just like a boil on your arm can get infected. Your glands down there can get infected, and you can get a fistula, and that's again a tract from the anus to the skin. Crohn's disease can get a lot of them, and they can be big and windy, and they can be pretty symptomatic to patients.
I see. So let's talk about risk factors, and if it's genetic. And if risk factors are the same for both Crohn's and UC.
So it's very interesting. So a very common disease process, and we're finding out more and more. And we know there are some genes that are associated with the development of having inflammatory bowel disease. There's IBD genes, the CARD15 gene, NOD2. There's a lot of different ones that are out there, but we don't really say that we can. And so patients can have a family history of it, but it's not like Mendelian genetics. You know, your mom has brown eyes, or and your dad does, or if you have blue eyes, both pairs got to have that. So we don't pass it like that, but there's for sure tendencies that occur within a family history that you can pass things along. There's been a lot of things that have been looked at in terms of what causes inflammatory bowel disease. There's no question it's probably multifactorial, and it has some environmental factors, where we live, where we're around. It's got some things that we're exposed to within that environment. It's got some hereditary factors. We know there's certain classes of population where inflammatory bowel disease or Crohn's disease even is much higher. The classic one is the Ashkenazi Jewish population. The rate of having inflammatory bowel disease is higher in that population. And then, you know, there's been even some thoughts about more and more emerging about the gut's microbiome, all the little bacteria that live in there. They're being blamed for everything these days. We're trying to finding a link with them, and that goes with Crohn's disease as well. And there's been even some studies in the past that have suggested some bacteria that we're exposed to that may lead to that. What may happen is you got a bunch of different factors that come together and trip off this cascade of events that are in susceptible hosts. So for whatever reason, you may have a makeup, not saying you have Crohn's or ulcerative colitis, that have a makeup that causes you to have be more susceptible to that. And then depending on kind of what you're made up of, what you're exposed to, and your family history all goes into setting that off. So that's a long way to say lots of different things we don't exactly know, but I think that hopefully within going forward, we'll be able to kind of hone down on that even more.
Okay, so let's talk about like diet a little bit. Are there any kind of foods that can cause or trigger these kind of conditions?
There's no real foods that are linked to necessarily saying that you're going to get inflammatory bowel disease. There's definitely foods that you can get colitis from, though, and that's just like you had a bad bug, right? You can have,
I see what you're saying.
And that's that. So again, going back to colitis being the inflammation associated with the gut that you can get bad diarrhea on, or C. diff colitis. But there's definitely, if you're having an inflammatory bowel disease patient, there's definitely trigger foods that will set off certain people, and that can that can change within the person. You yourself may find yourself in a situation where you say secretly, God, I can't eat pepperoni because I know that my stomach gets my stomach upset. And somebody else may say, man, I can eat it raw and it's not a problem. So foods within themselves act much more like triggers than anything else associated with the inflammatory bowel disease.
So it just depends on who's susceptible to getting that kind of
I would say that.
Yeah. And what kind of demographic is mostly diagnosed with this disease?
Well, it can touch everyone. There's no question. Like I talked about before, there's certain ethnic groups that are much more, in the classic one being the Ashkenazi Jews that I talked about before. It definitely can also run in families. We talk about a 15 to maybe 20% risk associated with having it run into families. Okay. Caucasian population for sure more. But there's Asians that can get it, African Americans, African. I mean, it can be all over in terms of that.
Okay. And so how do you diagnose Crohn's and colitis, and what kind of tests need to be done?
So in general, it's a clinical diagnosis. There's not a blood test that you can run. They've definitely had blood tests that we've used in the past that are much more, and there is still tests that are available out there that are called IBD panels that will run PINCA, PIASCA they've done in the past. These are the names of the small tests that if they're positive in one light or other, or even have a particular pattern, that you may say you're more apt to not only have inflammatory bowel disease, but you could have Crohn's instead of ulcerative colitis for those patients that don't fit a particular diagnosis with everything that's in a way, shape, or form. What I will tell you is the fact that we still look for kind of classic symptoms. So patients will present and they may have belly pain, or they may cause to have a belly obstruction, or they could have a multiple bleeding stools where they wouldn't have before. And the type of tests that we use at our disposal are making sure first and foremost that we get a good physical exam. So we look for things like what's their belly like? Do they have fistulas that I talked about before? Radiographic tests are still a mainstay, things like a CAT scan, or there's special types of CAT scans or MRs that are called MR enterography or MRE or CT enterography that look closer at the bowel to see the degree of inflammation associated with the bowel. And then we also use endoscopy, so we can do scopes that look in the colon, your standard colonoscopy, or scopes that look down into the stomach. Okay. And we kind of put together this whole picture, and based on all pieces of the pie, and very quickly you can come up with a diagnosis. So somebody who has then gets a scope, gets biopsies, and it looks like it's kind of a classic histological example of Crohn's in the setting of also having disease in the colon is also in the small bowel, and they fit that type of image, you're going to say they got Crohn's disease, and then they're treated as such.
So speaking of scopes, there's I think 3 really main ones, right? There's a colonoscopy, endoscopy, and there's sigmoidoscopy. Can you talk about the difference between those and what they are, just in case a patient is, gets to hear that they have to get that done?
Sure. So endoscopy is just a general term for meaning we're going to put a scope somewhere inside of you.
Okay.
And that can go into an orifice. So think about all the different orifices, that's endoscopy. So even an ENT scope can go look up in the nose or in the mouth, and they're technically doing endoscopy.
Okay.
Sigmoidoscopy and colonoscopy or esophagogastroduodenoscopy or EGD are all fancy words with the ending oscopy. So oscopy is you're looking at it. It's a scope. You're going to look. And then what you're looking at is that prefix. So colonoscopy is a longer scope, and it can look all the way around the colon. Remember, the colon is about 6 feet long.
6 feet?
Yeah, it's about 6 feet long. And some people have longer than others, but it's about 6 feet long. And so a colonoscopy, you attempt to look at the whole scope, and then in many cases what we can do is we can get through the little valve that connects your small bowel to your large bowel down by your appendix called your ileocecal valve, and we can get a sneak preview at the very end of your small bowel, which is called your terminal ileum. A flexible sigmoidoscopy is essentially a shorter scope that classically can only look for the left part of your colon, so your anus, your rectum, your sigmoid colon going backwards, and your descending colon. That's about 70 centimeters. And occasionally, in certain people who are easier to scope who don't have a big loopy sigmoid colon, you can actually even get up to the transverse colon in a lot of these people, but it's classically a left-sided scope. They're called flexible because you can move them, they're dilate them. There are such things called rigid scopes, and in our case, in the field of colorectal surgery, we use a proctoscope, which tends to be a rigid tube that you use handheld air to blow up the colon and get a good look at the mucosa. So those things are things that can be done in an office, a proctoscopy, an anoscopy, where you only look at the anus, or even a flexible sigmoidoscopy. The colonoscopy in general, even though I've definitely had patients, and I myself, when I had my colonoscope, I tried to do it without medication. I got about halfway around before I said, give me the juice. But most of the time you need to have a full bowel prep where you drink all the stuff, go to the bathroom, and then you get some sedation.
Okay, so this is what to expect. You're gonna have some kind of prep. It's gonna cleanse your system.
Yep.
Right, and then pretty painless with some drugs.
Yeah. So what I try to say. And this goes for all colonoscopy, for both colitis, IBD, ulcerative colitis. So if you're just in there for a routine colorectal cancer screening type full colonoscopy, probably the worst part of it still is the prep that you take the night before and maybe the morning of, depending on what your doctor prescribes for you.
It's a big jug, right?
Well, there's a lot of different types of preps out there, and there's pills and other things, and we're trying to get to the point where but there's still, the vast majority of patients are going to drink stuff that's going to make you go to the bathroom, and you're going to drink it in the beginning if you are one of the lucky few who get the big jug out there, and you're not going to go right away, and then all of a sudden it's going to hit you, and you're going to spend some time in the bathroom. But it does a wonderful job about cleaning out the bowel, and then so what people may not understand out there is the fact that the bowel itself, even if you're somebody who goes to the bathroom a lot, we all carry a lot of kind of waste stool in our colons and in our bodies, and that cleans it out. And so the other thing is that the colon itself, by and large, is collapsed on itself. It's got a lumen to it, though, just like a garden hose has a lumen to it, but the garden hose wall is stiff. Your bowel is soft, so it kind of collapses. So we use air to blow up the colon. So the other part of the endoscopy is we not only put in through the scope through, but we're also blowing in some air so we can take a good look around and make sure that there's no pathology in there.
Okay, great. Wow, sounds interesting. Now, is there a cure?
Well, for ulcerative colitis, so let me just step back, and I would say that in general, just like there's a spectrum of diseases, there's also a spectrum in terms of how potent that particular person is, meaning that I definitely have had patients with ulcerative colitis or Crohn's disease that really, they're not that affected. And some patients can really, with really mild cases, they may be on minimal medications at all, or in some cases, they don't even take medications, they just kind of cure it with diet or do whatever.
Sure.
Not cure it with diet, but manage it with diet. There's other patients that despite the strongest drugs that we do and the strongest medications that we have, they still have complications associated with it. And so if you take a look within those, we know that there's different classes of medications as well as surgery that we use in order to control the disease and also control the manifestations of the disease, which could be complications associated with the disease.
Flares, things like that.
Exactly.
So when is surgery needed?
So in general, just to get back to the medications and surgery, what we talk about ulcerative colitis. You have a certain set of populations that may decide that they're going to be managed with medications only, and they're successfully managed with that, or they're not, or patients don't want to take the medications.
Right.
And so ulcerative colitis could be, quote unquote, cured by taking out all the affected bowel. So what we do in that case is the affected bowel for ulcerative colitis is the rectum and the colon. We can remove that, and patients in the old school could either get a permanent bag, or nowadays what we're able to do, even through minimally invasive procedures, is to be able to make some small incisions, remove the colon and the rectum, and make them a new rectum using their small bowel called a pouch. And that pouch is called a J pouch or an ileal pouch, and there's different types of configurations, but the most common, the workhorse one, is the J pouch. And so patients theoretically can be cured of their disease with ulcerative colitis by doing this. Crohn's disease, again, thinking about not only the medications, there's different classifications for both of these diseases. So on the short end, there's things called aminosalicylates. Then other people can be put on some of the biologics or the immunomodulators, and they've got all sorts of different names and in ways that they work to affect our inflammatory system to try to quell that inflammation, and they can be adequately controlled. For Crohn's disease, it's a little bit different in terms of cure. It's hard to say that you can really cure Crohn's disease because it occurs from mouth to bottom, and there's not just a set area that we can cut out in that, because the rest of the bowel could still be affected.
Sure.
And so in those cases, we typically operate in general for Crohn's disease for complications associated with disease. So patients who perforate, patients who have fistulas that need to be taken care of, patients who get stricturing over time and get a bowel obstruction, or patients who continue to have problems associated with non-responsive to the medications that we need to go in there and take out that. So with Crohn's disease, we don't necessarily say, hey, we're going to take out all your colon and rectum and give you a new pouch, because it can just occur again in the small bowel and you could be having problems associated with that.
Sure.
So we try to limit our surgery on the disease aspect of where it's causing patients to have problems. We talk about function as well. You always want to consider, because you can't start just chopping away at the bowel or you'll be left with too short a bowel, and patients won't digest well and they'll have a failure to thrive.
So I was going to ask about that. So first of all, I want to clarify, J-pouch, you said it's internal, right? I mean, it's literally you're making them...
Yeah, thanks for giving me the opportunity to say that. So a lot of patients will oftentimes hear the term pouch and they'll think of bag and they'll think of ostomy. Yeah. Right. So when we talk about a stoma, so a stoma versus a bag versus a ileostomy versus a colostomy, all these different terms really are meaning the same thing. So a stoma is just, again, what we talked about, endoscopy and flexible sigmoidoscopy and colonoscopy. What we talk about in stoma is opening. So your mouth is a stoma. It means opening. But a stoma, when we think about it on the belly, is essentially an opening of the bowel to the skin. And ostomy is that art of bringing the bowel up to that. So an ileostomy is when we bring the ileum up, which is the tail end of the small bowel. The colostomy is when we bring the colon up, and it's a colostomy that you have. And patients wear a bag so that the waste can go into the bag and they can live a completely normal, functional life associated with that. A pouch, the way that I think about pouch and the way that we're describing it today, is constructing essentially a reservoir, a holding tank. Your rectum's just a holding tank for stool. I got news for you. It's nothing fancy. So it's an area where when stool goes down and reaches the rectum, you get the sense that you're like, uh-oh, I kind of got to go to the bathroom. But your rectum expands and allows you to have the ability to say, I'm going to finish this interview and then go my deal, instead of just right there. And it allows you to essentially have that capacity to hold stool. The pouch that we make is essentially called a J pouch, only because of the fact that we take the end of the small bowel and we bend it on itself in the configuration of a J. There's also an S pouch that we had one more turn to it. There's actually even a W pouch that's been described, but the workhorse is still the J pouch that we use, and that is the bowel itself on the internal, so people don't have to wear a permanent bag. As a matter of fact, there's different types of pouches that we make so that they don't have to do that. Wearing an ostomy or a bag on the outside is definitely a part of the process. And what I mean by that is the fact that if you had bad ulcerative colitis and you're on a bunch of different medications, oftentimes they get referred to us as surgeons because they're sick. And so we may do a multi-step procedure to get them to the point, over months, to the point where they don't have to wear a bag. And so the first operation may be, say, I'm going to remove all of your colon because that's pretty sick, and bring a loop of bowel to the skin in ileostomy. The second type of the procedure a few months down the road is going to be, I'm going to take out that rectum, I'm going to make you that pouch, that new rectum with the small bowel, and connect it down to the bottom, down to your anus. And again, I'm going to bring up a loop of bowel to the skin so that stool can be diverted so that pouch can heal. And then a couple of weeks down the road, I'm going to be able to take this down. So the fact that you wind up with no bags, but it's occurred over a few months to get you to the point where you're there. And so patients can oftentimes get, exactly like I wasn't super clear before, confused with the terms pouch versus bag versus ostomy versus everything. But there's even a type of pouch that we make here at the Cleveland Clinic. It's one of the few centers that do it, that is called the K pouch or cock pouch. And that type of pouch is a pouch that you also don't have to wear a bag, but it's for ones that we actually bring to the skin. And it's something that patients we make, it's kind of got a ball valve to it that we bring up to the skin, and you intubate that with a tube, so you drain the waste, and then patients can go about their lives and do whatever they want to do and not have to wear the external bag. And then every so often they just go ahead and intubate the pouch. And again, we're one of the few centers in the world that do that.
Is this something, if someone had the old style stoma bag, can they get this new K pouch?
There's a lot of considerations to it. And Coke pouch has been around a long time, and there's certain aspects where people would want or not be able to do it, but it is definitely something that is in the armamentarium for what we have.
So what would you say to someone that has stoma bag is the one that would be an external bag, correct?
Correct.
For quality of life, what kind of things should they be expecting, what to do daily, things like that?
So there's a difference between a colostomy and an ileostomy for sure. In general, if you just think about the fact of digestion. So when we eat, kind of take a step back from the question to really kind of understand this. When we eat, the process of digestion is we eat, goes down our stomach starts to use the acid, and then it gets the enzymes from our pancreas and our liver, works its way through the small bowel where really it gets not only broken down, but we get a lot of our nutrition that's absorbed and everything. And your bowel actually secretes fluid in and also absorbs fluid out to the point where, and when it goes through your jejunum, which is several feet of jejunum, and your ileum, which is the tail end of the small bowel, and comes all the way down here, and most people down to their right lower quadrants where your appendix sits, that stool, when it reaches the colon, is still kind of a thinner liquid. Maybe in the best of worlds, it's maybe like grits or something like that. But by and large, it's pretty liquidy. Your colon's job, actually, with the workhorse of it being the right side of the colon, is to absorb water. And so then it absorbs water throughout the colon. And by the time it gets to the left side, it actually forms stool. And so certain people, maybe not, for whatever reason, maybe not as either efficient or that, or they can't kind of form stool, and they have looser stools. And again, the looseness of your stools or how many times you go is so individualized, and there's definitely probably men go more often than women, but there's so many things that are emotions, what we eat, the time of the day, your patterns that you fall into, go into how many bowel movements you have. That's a very common question that I get asked. But to go back to the question you asked at hand, what to expect. So if you're somebody that is missing your colon, you got to go back to what is natural. So if it's natural for you to typically have a little bit more liquidy stool, if you have an ileostomy, then that stool that's going to come in the bag tends to be a little bit more liquidier. Now, over time, your small bowel gets much more efficient, and you'll see it thicken up a little bit. And what patients notice with an ileostomy is the fact that oftentimes, no matter what they, or depending on what they eat, or sometimes we put them on bowel-slowing medications or bulking agents like fiber, Metamucil, Consul, Citrusol, some of these other things, or bowel slowing medications, Imodium, Lomotil, some of these other ones that will thicken it up so it gets to be a little bit thicker. It also helps the fact so you don't get dehydrated. If you have a colostomy, you got all your colon in your play, or for people that have part of their colon removed, some of your colon in play, to the point where your colon still has the ability to do its job. So for people who have a colostomy, they may, just like they have a bowel movement, what comes out of their colon may not be as often, and it may be thicker stool. And so I definitely have patients with a colostomy that can almost train themselves over years to have a bowel movement just through that. And sometimes they wear a bag, and they've got a small amount of patients that actually don't even wear a bag. They've been able to do that. But it goes back to the anatomy and the physiology of how we're wired, such that you could say that what to expect is much different from somebody who has a colon that's to the skin versus an ileum that's to the skin. The one point that I would like to make sure that patients, especially patients that are faced with the recent being told that, hey, if you go through this, you could wear a bag, and the bag could be permanent. That's not only something that is body altering, but it's mind altering. Imagine if I told you right now, I don't know you, I'm assuming you don't have a bag, but if I told you right now and I said, listen, whatever's going on with you, you're going to have to wear a permanent bag. That's a shock to most people's systems. And one of the first things they say, and a very common thing that they say, oh my God, I'd rather die. My own mom said this when she was faced with her terminal illness. She would say, I'd rather die, Scott, than get with it. And then it kind of sits in. And what most people find after they go through is, in many cases, their quality of life was better than it was before. And you can do everything. I have buddies that have climbed mountains, done Ironmans, done just about you name it. I have somebody that fashioned this wonderful padding apparatus so she could still play rugby using a bag. And you find that not only can you do everything that you want to do, but you can continue to have that solid quality of life. And in some cases, patients have been trying to avoid a bag or avoid an operation that had the threat of having a bag for far too long, where they lost their quality of life. And it's not an uncommon finding that they come back to me in a postoperative setting and say, God, I wish I would have got this thing a long time ago, because I've been suffering for a long time.
Good. I'm glad you touched on that. I think it's very important. So let's talk about some lifestyle changes for people with Crohn's and colitis, from stress management, exercise. I know we talked about diet, but if there's any kind of food that triggers or anything like that, what is the ideal lifestyle?
So what I would say is that I would hope that for most people that they would have a very normal lifestyle, that they would fall into a pattern. They could be either taking care of any complications that they might have with medications or even with surgery to get back them to doing everything that they wanted to do. There's no question, though, that there are certain foods that trigger, and the foods, like we talked about before, that may trigger one Crohn's or ulcerative colitis patient may not be other ones. There's definitely diets, elemental diets, or other diets, especially in kids, specialized diets that they may do that are out there that certain GI doctors use that could, for the severest of Crohn's patients, will still allow them to get to be able to take in nutrition through the mouth and get, have weight gain, not have weight loss, and be nutritionally replete. But in terms of being able to exercise and be able to do all the things you want to do, there's really nothing that they can hold them all the way back from doing that. During a flare, there's no question that patients can be sick. Right. And depending on the degree and kind of potency of that flare and where it affects, especially with how that flare is. So is it bloody diarrhea that won't come down? Is it abdominal pain that just is occurring? Is it a bowel obstruction that can come up, or is it a fistula that has reared its ugly head? So depending on what's going on with that patient may affect that time that may have to be taken care of with either medications and admission to the hospital, going on IV nutrition during that time, or even surgery that we have to think about. But in general, I guess the biggest take-home message to answer your question is their quality of life, the things that they do, the exercise, and hopefully even some of the diets that they eat, if their disease is well controlled, can be as normal for them as for anybody else.
That's great. Excellent. And I want to go back to the microbiome. I know you were talking about like the gut germs. Are any changes in the microbiome in your gut, would that change things for Crohn's and colitis?
Well, I think that's what's going to be the next horizon. As a matter of fact, I know that us, like other institutions, are collecting stool samples and getting biopsies and stuff and really studying the role of microbiome for inflammatory bowel disease. And, there's some preliminary reports that have some suggestions. We're not there yet, but I do think that's the next thing on the horizon. Just like it's the next thing on the horizon in terms of healing when we put bowel specimens back together, when we cut out a piece of bowel and link them up, and whether or not that leaks. John Alverdi out of the University of Chicago has done a lot of work in this. Cancer operations, Matt Kalady here in my department is an NIH-funded research that's looking at the role of the microbiome. We have a lot of different things, and I know that our GI department, led by Dr. Miguel Ruggiero, who's our chair here, and others within DDSI are taking a look at the role of the microbiome in terms of what it does, not only in terms of causation, but treatments, and then also things like flares and how we can affect it.
Great. Now, I want to talk about, with Crohn's and colitis, do they have an increased risk for colorectal cancer?
Yeah.
Should they get their colonoscopies earlier?
Absolutely. So in general, what we talked about in the past is it used to be thought, if you go back 20 years, that maybe it was just ulcerative colitis that was associated with increased risk. And what we found through the thing is that inflammatory bowel disease does have a higher risk in general than the general population. Really, when you break that down further, if you can take a look, especially it goes to colorectal cancer, there's two things that we think of. The first one is the length of time that you've had it. So meaning that if you've had it for a long time, that's had that inflammation, which is one of the potential things that can cause the cells to go awry and ultimately trigger on a tend towards having either dysplasia, which is the cells look funny underneath the microscope. It's along the pathway to cancer, versus also the degree of how much of the bowel is affected. So if you've had it longer, or your gut is more affected, a pancolitis instead of just maybe a part of your colon, those patients that have had it longer and their colon is affected are at a higher risk. And that is for both Crohn's and for ulcerative colitis. The one thing that I will also say about that is the traditional pathway to having cancer in non-IBD patients has a pretty set pathway where you go through a polyp, the polyp becomes dysplastic, the dysplasia goes along, and then ultimately you get a cancer. There's other types of polyps that have different pathways, and whether it's BRAF or serrated polyposis, there are all these fancy doctor terms. You got to think about it. You're starting with somebody that's something that's normal, and you're going to something that's abnormal, and ultimately invading into the bowel, and that's the diagnosis of cancer. IBD pathway can be different pathway, and that pathway is outside of the traditional pathway of the adenoma to carcinoma sequence. So not only is it important that we control their inflammation, but that we also follow them to be able to say that we want to follow you at a more frequent interval to make sure that you don't have cancer, because it is a higher risk than the general population.
Sure. Great. And last question for you.
Yeah.
I want to talk about when it comes to pregnancy for women, because I have a lot of friends that are childbearing age, and some do have UC. And I just wonder, is it hard for women to get pregnant? And if they do, what does that mean for the baby? Do they go through intermission during, or what's going on with that?
Yeah, so this is a whole, I think that it's been around, it's been something that's been known for a long time, that there's no question that, you know, some of the inflammatory things, including inflammatory bowel disease, affect women's ability to get pregnant. But it's not talked about a whole lot, and we don't, you know, to know exactly what degree. I know that there's multidisciplinary clinics that are taking a look at that. I will say this falls into two different patterns. The first one that you have to think about is you have to think about the fact that what is going on in terms of the overall system that might be affecting their ability to get pregnant. And the second part is there any aspect in terms of some of the things we do to them as surgeons, or even the medications that may affect that? And I think the medications, the aspect of that, especially with some of the newer biologics, remains to be seen. Sure. And that's something that with time we'll be able to know that maybe there's certain medications that make it more difficult than others. What I can tell you from a surgical standpoint is that any pelvic operation that we do, including one of the ones for ulcerative colitis, has the potential to form scar tissue. And the woman's ovaries and their fallopian tubes are sitting right down in that area. And so there's been times in the past where we've had people come in and pexy their fallopian tubes up, so to kind of get them out of the pelvis, or even wrap at the time of the operation, wrap the fallopian tubes in some anti-adhesive type things. And people have tried a lot of different things to try to minimize that scar tissue. Probably one of the best thing that's come along is having minimally invasive surgery. Some of the minimally invasive surgery that we do, like here at the clinic, allows you to have less scar tissue, which then will have that secondary scar tissue, hopefully not there, towards where a woman's fallopian tubes.